باكد مع الاخ الفاضل الدكتور محمد عبداري شكري واعتزازي بمعهد دمنهور. صراحه هو لاند مارك في النفرولوجي في ايجيبت. 22 سنه كامله، ما اعتقدش ان انا خلفت مره، اعتقدش يعني، من ايام زمان خالص. وصراحه كل مره في بروجريس، وما شاء الله دلوقتي بقوا اعلام قد الدنيا، كل واحد ماسك برانش لا يقل عن اي جامعه. هو جامعه فعلا في وجهه نظري الشخصيه، بالعكس انا وجهه نظري هو زاد عن اي جامعه كمستوى وكبراكتيكال وكريبيتيشن وسمعه واشخاص. يا صراحه انا اعتز ان انا يعني بحضر هذا المؤتمر، فشكرا جزيلا والله. The topic of today is rituximab in glomerulonephritis update. It is a very difficult topic, need a lot of time, but I'm trying to be to the point of this topic. And the reason, as Dr. Walid mentioned, the rituximab is now available to use, you can say, than maybe 5-10 years ago. But is it better to use rituximab? That's the question. The agenda include, of course, rituximab, and its use in glomerulonephritis, including minimal change, membranous nephropathy, IgA, lupus, IgG4 nephritis, and primary focal and C3 glomerulitis, and maybe others, but I don't have the time to speak about transplantation in using of rituximab. And a final conclusion. But as the last maybe 7 years, I started usually by debatable conclusion to get the message loud and clear what I think it is correct, and the rest of the lecture is trying to support what I'm trying to say, so as to deliver the message. I got 18 conclusion in this debatable conclusion. Rituximab, actually number 1 is the most important. Actually, this is the conclusion of what I'm thinking about rituximab. Rituximab efficacy in GN include 3 groups, maybe others. It is effective in minimal change disease, going without saying, as you will see from the paper. And maybe in the IgA nephropathy, until a couple of years, it is used for membranous, primary membranous, but 3 RCT trials showing that it is not as it is. Its use is questionable in lupus nephritis, IgG4 nephritis, and definitely, although in medicine there is no value of using it in primary focal and C3 glomerulonephritis. Of course, it can use in ANCA-associated vasculitis and anti-GPM disease and good posture. In a word, it is used in podocytopathy. That's why it is used in minimal change efficacy. But who in earth will treat minimal change by a very expensive drug like that, while you can control minimal change by a small dose of steroid? And it can be used in fibrillary and others as hepatitis C, cryo, and monoclonal gammopathy. And the transplantation, actually, it is not the first step in antibody acute cellular rejection, but it can be used effectively in either acute antibody-mediated rejection or the active form of the chronic antibody-mediated rejection. Rituximab mostly used at the end of the road. This needed to be changed, actually, because it may be a victim. It is used in resistant cases, which may undermine the need or its actual benefit, because it is the end of the road. In membranous, there are 3 randomized controlled trials in the last couple of years, which it changed actually. That's why medicine is changed in the last 2 years. It changed the concept of using rituximab in membranous. And the word what Professor Elbaz mentioned to me is old is gold. And that's I will mention in a minute. Mentor, which is membranous nephropathy trial of rituximab against cyclosporin, and Starmin, which is the sequential therapy with TAC and Rituximab, versus the modified Poncelli protocol, including glucocorticoids and cyclophosphamide, and they show that this combined Poncelli protocol is better, even better, and you will see in a minute. And the third trial, which changed our concept in treatment of membranous nephropathy primary type, is what is called RI-Cyclo, which is comparative study between rituximab, but the first arm is still cyclo and glucocorticoids. Actually, these three trials is the main trial to be head-and-head comparison between rituximab and the others. That's why he is put from the start in a trial to decide about its benefit. Rituximab is still, after 2 decades, an expensive drug without a concrete established value. However, it may be a victim. Rituximab is related to podocytopathy and B cells and antibody-mediated. That's why the three pathophysiological mechanisms can explain why it may be effective in a diseases related to this. But this proved efficacy in antibody-mediated rejection, minimal change, and anti-GPM disease. It may be even the first treatment. But actually, in focal segmental, if you consider it as podocytopathy, and the word of Glassock about 2 years, he considered focal segmental as a lesion, a pathological region rather than podocytopathy. That's why maybe that rituximab is definitely has no role in primary focal segmental glomerulonephritis. Rituximab, not anymore as it was planned to be used in GN. And the word which I must emphasize, we cannot start from the beginning. We must have the data. So not an expensive drug to use it right away. It is only used in certain situations. Of course, the Starmin, as we showed, that alternating glucocorticoid cyclophosphamide is superior than the TAC and rituximab and has a risk, but it is an accepted risk. However, sequential TAC and rituximab involved delayed delayed outcome and worse performing than rituximab. The RI-Cyclo pilot study did not demonstrate superiority of glucocorticoid over the rituximab, but no difference in adverse effect. So why to use this expensive drug? Overall, the Starmin and the RI-Cyclo confirmed the efficacy of this old weapon, the glucocorticoid cyclophosphamide, in patients with a high-risk membranous nephropathy, and not all primary members will use immunosuppression. And the role of rituximab is a valid alternative. Even corticosteroid and cyclo may be definitely superior than TAC and rituximab. So it is back to the old weapon, especially in membranous, because Poncelli regime even better than the others. Old is gold in membranous nephropathy. And the last debatable conclusion is that's make difficult to think about rituximab. If you review the literature and the article, the dosing protocol is different. In the same disease, you will maybe more than 5. You may get only dose to targeting B-cell depletion to be sure that the B-cell depletes. You may give 4 doses of 375 milligram per square meter every 2 weeks. Or you will give only 2 doses 2 months apart and for 4 months, not 4. You may give only 2 doses 1,000 milligram with 2 weeks apart. Or you are giving only 1 single dose of 1,000 milligram. Or you will give 1 or 2 doses of 370 milligram, 75 milligram. And that's why the decision about efficacy is even debatable. If you go to the PubMed and put rituximab, you will get about 29,000 reference. And if you put rituximab plus glomerulonephritis, you will get about 9,000. And one of the cornerstones, just to justify what I have already said by a debatable conclusion, the management of membranes in this NDT 2022 showed that although the 2021 kidney KDUQI guideline needed to be changed after the 3 trials to get the cyclo and the glucocorticoids back to its level. If you go to the up-to-date, the membranous nephropathy chapter is changed in October 2022 to justify the use of the cyclo and glucocorticoids more than the rituximab and even more than the rituximab and the TAC in the primary membranous. And there is a recent clinical trial. Of course, the assumption is rituximab has been demonstrated to be efficacy in proteinuria, but actually it is not the case. So the Starman coming to say that it is maybe would be superior, but actually this is not documented. And this was not the case after this comparable 2-arm study. And the comment is alternative treatment with corticosteroid and cyclo is superior than the sequential. Actually, this review article by Pierre Ronco, which came to Egypt in 2014 in the journal Clinical Medical in 2021, summarized the 3 trials of membranes. I'm insisting about membranes because this is the only disease which has got new recent RCT trials, 3 trials, to check rituximab beside others. And he got the same conclusion. If you put the 3 trials on side by side, the mentor rituximab with cyclo, the modified Poncelli versus TAC and rituximab, and the modified Poncelli versus rituximab alone, but the dose is different. And you will get this. Rituximab definitely in the mentor study has got a 60% response rate in comparison to 50%. But if you got corticosteroid and cyclo, it is 79 versus 50. And if it is rituximab alone, but it is a bigger dose, it is 70 versus 60. But the most important is the remission will not last better except with the cyclo and the cyclophosphamide and glucocorticoid, even more than the others. And this is the picture of the immunohistochemistry in the membranous nephropathy, although all 4 pictures are the same because the ingredient which are used, which is the nomenclature, is different. A new paper about rituximab used in adult glomerulonephritis is a rationale, and if you go to this, I will not go through this, but I will just tell you that in, for example, focal segmental with this man, Franzo, it is the rituximab causing only no remission in 7 out of maybe of 8 cases. And the same to justify this. If you go to this autosomal resistant versus lupus nephritis and minimal change and focal segmental, it be helpful in the ANCA-associated vasculitis beside other. Another paper with the dosing scoping review, and this is the graphs which I need to stand. This is different protocol in the same disease. You will change the color and you will get in the same disease, the comparison of rituximab versus other has 5 different protocol of management. And use of rituximab as an off-label. And this is a picture which I like, although I don't have the right-hand side is the literature not approved, the off-label. And the off-label including focal segmental others, and there is no difference in remission. But in this right side, they got the 2 possible responding, which is the minimal change and the membranous, and the remission, of course, is much better. And this is the plan for the protocol. And if you go to this, and this is actually summarize my debatable conclusion. The membranous, the minimal change, and the IgA. Look to the curve. They are the things which complete remission is observed. The others, like for example, primary focal, the green column does not change. And this is to see the remission or no. of course, the blue line in minimal change, complete remission of using the rituximab. But I'm trying to insist, who will use rituximab for minimal change? We can use different others which are cheaper. And if you go to this curve, the lupus has very debatable things, but actually cannot be used in class 4 or even class 5 sometimes, but it is used in class 3, and class 3 responding to the usual treatment, even steroids alone. And this is the curve again to justify if it is off-label, there is no difference in all the others except minimal change and membranes before it changes. So I will have just 5 slides, maybe to left, just a text. It is the antibody-mediated vasculitis, ANCA-related, related to B cells. That's why in 2 randomized trials, the rituximab is better, because the pathophysiology is justifying. The lupus is debatable, which type of lupus, and the LUNAR study did not show any benefit of rituximab over the others. And still in the lupus, the LUNAR study, although there is some podocyte injury, and the podocyte is not a proliferative lesion, that's why it may be in class 3, not other classes. Idiopathic or primary focal segmental, although it considered podocyte, but the rituximab is a complete failure of this category. Immunoglobulin IgA, it may be helpful, and the antibody-mediated anti-GPM basement antibody GN, it may be helpful because it is related to the antibody. And the guideline recommend initiation of immunosuppression with cyclophosphamide and glucocorticoid plus plasma exchange, but suggests still rituximab. And in retrospective study, it shows a benefit. So let me finish, my dear colleagues and audience. The last statement in absolute term, rituximab is a very expensive drug without proved efficacy over the old weapon in GN. However, it may be a victim as it is always used, except in membranous. We do have 3 trials. It may be a victim as it always used as a last step in management. And however, in antibody-mediated rejection, of course, it may be the first line with the other as a conjoint treatment. And thank you very much.